Hello and welcome. We're going to give everybody some time to join the webinar, and then we will get started. Just a few more minutes and we will get going. And welcome everyone to TMA's Ask the Doc webinar series. My name is Rachel Bromley, and I am TMA's Senior Manager of Patient Education, Support, and Advocacy. I will be your host this evening, but it is not about me. It is about our wonderful physician that we have with us today. I want to say in the studio, but I'm actually in the conference room in Columbia, Maryland, and she is not that far away, Dr. Lisa Christopher Stine. She is a professor of medicine and neurology and director of the Johns Hopkins Myositis Center in Baltimore, where she has been privileged to care for hundreds of patients with myositis and to build the Johns Hopkins Myositis Center to be one of the largest of its kind in the world. She is a board-certified rheumatologist and clinician scientist specializing in research and clinical care of those who live with myositis. She has a strong interest in patient-reported outcomes and has been the co-chair of an international effort to develop a novel patient-reported outcome measure. Dr. Christopher Stine also serves as a Deputy Director of Telemedicine and Rheumatology, as well as a board member of the Institutional Review Board at Johns Hopkins University. She is a proud member of TMA's Medical Advisory Board, and we are so happy to have her. Welcome. You are on mute.
Thank you, Rachel. Thanks for the wonderful introduction.
You are welcome. So let's talk a little bit before we go to questions. If you have a question, go ahead and put it in the bottom of the Q&A. We are really going to be able to focus on our in-live questions. We have a few emails submitted, but most of them today are going to be in the Q&A. So go ahead and start inputting your questions. But first, we'll let Dr. Christopher Stine talk about her work.
Yeah, thanks so much, Rachel. For those of you who know me, know I've been in the field for a long time. I've been privileged to, as I've said, work with a lot of patients with myositis over the years. We established our Myositis Center here at Hopkins in 2007. So it's just been our 16th year anniversary this past March, which is hard to believe. As part of that work, as many of you know, maybe some of you do not, we really have a unique experience here in which we utilize our clinical care at the same time as our research efforts. And that means that those of you who have seen us with your permission, and most people do provide their permission, but not all, it's not required at all. However, with rare diseases, it's helpful to build a cohort, and we've done that. So a cohort of patients who we've seen over the years who then provide us permission to use in a de-identified fashion clinical variables so that we can answer questions that you ask me, like how long will this happen, or what percentage of patients get this or that. So that's sort of where some of those numbers come from in the back of our cohort. I see lots of questions starting to populate, and they gave me at least 8 to start. So I think I should talk less about what we do and more about what you want to know about. I can certainly play talk show host and fill in the gaps if there's gaps. So I'm going to, I guess, Rachel, is it okay with you? Oh, I don't know if you are okay if I read them out loud. Is that all right? Or did you want to moderate with me answering? I'm happy to do whatever works best.
You can read them out loud, just we don't use names.
Okay, all right.
So even if you see the name, you don't say the name out loud.
Got you. Thank you for letting me know that. Okay, so the first question is asked, IBM, so inclusion body myositis, those of you who are on here, I assume are pretty well schooled. Actually, I will say that some of you are so good at this, you teach me things. So I know that the student becomes the teacher and that you are all well read, and I learn a lot from all of you too. But IBM, or inclusion body myositis, has made my core muscles very weak. So core meaning the, the truncal muscles, and it's hard for me to hold myself upright. What exercises can help? All right, so this is a global question, and let me just, not to punt this, but to tell you this. So a lot of patients often say to the doctor, at least to me as a rheumatologist, what exercises should I do? And I don't generally, so exercises should usually include not heavy weights. So one of the things we recommend in general globally for exercises in myositis is not to use heavy weights, but to use more repetitions than weight. I will also tell you that I did not go to school to learn about exercise. Who does do that are physical therapists and occupational therapists. The word occupational therapy is confusing to people. So occupational therapy generally deals with the upper body, physical therapy, essentially the whole body, but more lower. So if I feel like you have upper and lower body weakness, I'm going to refer you to one of two people. I'm going to refer you to a physical or occupational therapist and/or physical medicine and rehabilitation physician. And I think that it would be here's a future idea for you for sure for an Ask the Doc, is to ask a doc in this sphere. So exercises, and I believe Dr. Helene Alexandersson, who's a doctor, who has her doctorate in physical therapy from Sweden, from the Karolinska Institute, studies this. Her videos are on the web for the Myositis Association. And exactly what muscles you should use, I really can't tell you. And the second reason I can't tell you, and every physical therapist will tell you, is that these programs are individualized for you. So while so again, I think your question brings up a few things. One, who should you see and ask this question to in real life? That should be a physical therapy team. So you should ask your doctor for a referral, preferably to somebody who has seen myositis, which is hard because it's a rare disease. So I like to recommend centers of excellence, such as our own and others who have physical therapists who work with them. Our physical therapy team here is amazing. They've been learning about myositis for as long as we've been treating it. So that's number one. They go to school for 5 years or longer, have a doctorate in physical, in physical movement and education of exercises in the body, that we don't train that way. Almost no physician outside of physical medicine and rehabilitation specialists trained to have that idea of in-depth knowledge. So specialized team, number one. Number two, repetition without a lot of heavy weights is for sure. What you definitely don't want to do is not do anything. Number three, individualized programs work better than global programs. If you have nothing else to do and you're in the middle of an exercise desert where there's nobody to consult, and you happen to live in a rural area that doesn't have easy access to physicians or to physical therapists in particular, then using the exercises that are provided on the web through the Myositis Association are helpful to help guide you, but preferably having an individual program. And then asking your therapist to be able to translate that to a home program. The reason that home therapy is not usually as effective as physical therapy in-house, or having it done at a center or a standing facility or a hospital, is because people tend to not do them at home. So home programs are very good, and once they're specialized for you, very helpful to use, but you have to be a good steward of doing them. And most people just really, it's a human nature not to necessarily do them. So I know that was a long answer to your question and didn't actually answer the question for you, but I hope that that helps you at least plan how you'll answer this question. And that question really needs to be individualized, but put in the hands of a very good physical therapist would be in that way. Physical therapy, occupational therapy, because you're talking also about your core, upper body. I'd consult with both of those specialists, and I think they should be able to help you. Next is, I was diagnosed with dermatomyositis in 2010. I've developed tinnitus, which is ringing in the ear, started constantly after my COVID booster. It's relentless. I've read about autoimmune tinnitus. Do you have any experience or thoughts on this? I'm seeing ENT next week. I don't, actually. So I will say that, in general, I think that the net positive, we've actually studied COVID boosters. We didn't see any increase outside of anything serious, that required serious flares of the disease. We didn't specifically look for this. And, again, this is an individualized question. And 100% the person that the specialty you're seeing is who I'd refer you to. So I think ENT is your best bet. I haven't seen that. And I'm, again, polling my colleagues. We talk a lot, and we present cases, specialized cases, once a month at our own conference. These are de-identified, but we present the cases to each other. And I've not heard of this come up either in the setting of a COVID booster or in that's not an associated autoimmune finding in myositis. The unrelated to myositis autoimmune findings that we see is more often in the thyroid. So we do see autoimmune thyroid disease a fair amount, something called Hashimoto's thyroiditis, but I haven't seen tinnitus or ear-related autoimmune issues. Again, these are, I wish you luck, but I really think that seeing ENT is the right place to go. And if you had seen me in consultation, that's exactly where I would send you. I know it's miserable and I feel for you. It's possible that this is what is called Meniere's disease, which has a triad, including hearing loss, some vertigo, and this ringing. So it may be the early start to that, but I don't know of any literature or my own experience where myositis and autoimmune tinnitus overlap. Okay, next. Very interested in the patient-centered research and the involvement and progress being made with myositis patients. Can I talk a little bit about the work and how can patients get more involved? This is awesome. So I think part of what we do is under the framework of, there is something called OMERACT, which it stands for Outcome Measures in Rheumatology, or outcome measures in rheumatology clinical trials is what it used to mean, but I think it's more broadly across all rheumatic diseases. And under that framework of patients, we have what's called patient research partners, or PRPs. I would say maybe in that regard, if you're really interested in getting involved in work like that, maybe you could submit your information to Rachel or others offline, and I'm happy to talk about it. So a couple ways to get involved. We have partners that we have been partnering with in this space for over 10 years, and they help to write the papers with us. They help advise us on, we are actually toward the end of our work in this space, trying to find good patient-reported outcome measures for clinical trial work that represents what the patient tells us is important. So I'll back up to say that we had all kinds of surveys, scales, and when we walked them through those scales with patients and they talked us through them, a lot of times they said, well, that actually doesn't make a lot of sense, or that question's ambiguous, or I don't even know what that means, or that's too intimate of a question, I'm not going to answer that. And so I think over time, we've learned that some of the questions and the way we ask them really need to have a patient lens. I think to say to, stay tuned for that, it makes me realize that your question suggests that when we perform these types of interviews and such, that advertising them broadly through the Myositis Association may be important. I think that patient advocacy associations like TMA can help fuel that, maybe talking about that a little bit more and having patient-directed or patient-associated research partners through TMA would be something to consider. It's something I don't know if would be a priority item for them, but certainly I'd like to be thinking about that more. So your question makes me think about maybe having more formalized ways to be involved directly as patients. The other ways we involve you as patients is in survey data. So you'll see them come out broadly from the TMA sometimes, where you'll get a survey and we ask for your own experience. More and more, I'm trying to hear about the patient experience with disease. This has happened a little bit more for me in inclusion body myositis, where I started to see that I think that there are women experience the disease a little different in my experience. Again, don't know this for sure until we know this a little bit from some research my colleagues have done. I've been involved in that research, but a lot of that research was directed by Dr. Tom Lloyd in our center, where I started to see some patterns. And in my own clinical work, I've seen the same. So I think that it may be important as a patient to help inform not only answering surveys that we give, but maybe even having a panel of patients that suggests information that you feel might be missing. And maybe that's something we can talk about further, even at the TMA annual meeting. So the work that's being done now is done under an organization that's international in scope. We have a patient from Holland that's been working with us and a patient from the US for over 10 years. And then the patients that have participated, over 500 of them, were either in a focus group where they were invited. We did actually 2 focus groups at the Myositis Association many years ago when it was actually held out west, trying to get geographic representation from the United States. So sometimes within the confines of TMA themselves, they facilitate excellent patient outreach. And you've put a seed into my head to think a little bit more about how we should think about this together as patient and physician. I thank you for your question. I'm going to think about it a little more to maybe round it out so that beyond survey work, that patients who have interest can be involved in more meaningful ways with interface with the doctors themselves. So thank you for that. What is Plaquenil's role in treating dermatomyositis? So Plaquenil is the generic name for a drug that I think everybody may have heard of in the context of COVID. It became a hot button topic, which is hydroxychloroquine. Hydroxychloroquine, or Plaquenil, is something called an immune modulator. So it doesn't suppress the immune system, it modulates it. It does it through some part of from a basic science mechanism. It uses something called the toll-like receptor system, which is not important for today's topic, but it's a unique way of modulating the immune system without suppressing it. Plaquenil, or hydroxychloroquine, first gained probably its most important role in lupus. Lupus and myositis, of course, are not directly related, but dermatomyositis, the rash of dermatomyositis and the rash of lupus look a lot alike under the microscope, meaning that if I do a punch biopsy, a little hole punch of your skin with a dermatologist or one of us, we take a look under the microscope and we can see that the inflammation pattern, that the way that the skin is affected, looks similar. So people said, well, look, Plaquenil, or hydroxychloroquine, works pretty well for the skin and in lupus. Maybe we can use that in dermatomyositis. And in fact, in some patients, it really does. It helps the skin. In my personal experience, it's a little more helpful in the juvenile form of dermatomyositis than the adult form. And there is one antibody. So an antibody is, if some of you have seen me or my colleagues at the Myositis Center, we try to identify which antibody you have. If it's known, there are 5 of them associated with dermatomyositis. One of the more rare ones is something called anti-SAE. And one of my colleagues here, Dr. Livia Cassiola-Rosen and Dr. Dave Ferrantino, their group in Stanford, helped to identify the fact that Plaquenil, or hydroxychloroquine, can cause what's called an exfoliative dermatitis, a very severe rash itself. It doesn't help the rash, it makes it worse. And in those patients who have that antibody, for whatever reason, hydroxychloroquine, in my experience, should be avoided. It can cause more of a problem than help. What I generally say about Plaquenil or hydroxychloroquine is it's not generally harmful. It more often just doesn't help. It doesn't really harm. So if you don't have that antibody and you have dermatomyositis and you want to try it, we try it anywhere from 1 to 3 months to see if the rash is helped. I often use Plaquenil more often as a rheumatologist for minor joint disease. So joint pains that are not a huge inflammatory arthritis, but arthralgia, which is pain in the joints without swelling that I can visibly feel or see. That's also a helpful adjunct. We'll use it in dermatomyositis for people who have both skin and joint involvement, often very helpful, just to take the edge off of that joint pain. So again, I think the role in dermatomyositis is more helpful in the joint disease when it's present than the skin itself, but many people will try it for the skin for a while. I just don't think it's generally helpful for many people, or it's good as an adjunct where you may be on one immune suppressant, it's not quite taking care of all the skin rash, and we add on Plaquenil or hydroxychloroquine to just help kind of a synergy between both of those agents, and that's another way in which it can possibly be helpful. Okay. I will see your patient. Yes, well, this is public knowledge. In general, this is not HIPAA non-compliance. So I think if it's in Rolling Stone, it's okay. I'll see your patient, Peter Frampton, in concert Monday. Good for you. I've seen him at least 5 times, never disappoints, but he is not meeting anyone this time. I have one question for him, but you may know the answer. By the way, the reason I believe that Peter's decided not to meet is because of the potential for exposure to COVID and other diseases. I think he's trying to keep himself as well as possible, and I cannot blame him. So I don't think it is in any way something that I think that's a good decision for trying to stay healthy when you're seeing a whole lot of people come through a small space of backstage at a concert. So maybe you know the answer. How many hours a day does he practice? I don't know this answer, but a lot. As a former guitar player, I know it isn't about finger strength, but dexterity. So without being completely, I have no idea, but I would say hours and hours. So as you know, a professional guitarist, especially one such as he, who started, I think, I want to say, I'll quote him somewhere around age 10 or earlier. So he's been doing this for 60 years. Funny enough, before I could disclose anything about him because of HIPAA privacy laws, before he decided to go public, I would tell my patients, hey, I have a guitar player and I've noticed that his hands seem to be maintaining a bit more dexterity because inclusion body myositis can affect the finger flexors. If you play piano or guitar or type every day, something that's using your finger flexors in that way, I think it's likely to be helpful. So I think the answer is use your finger flexors often and daily. How many hours a day does a professional guitarist have to play? A lot, I assume. But also remember, it's not the hours of day that we play, it's also the number of years that led up to that. You can't go back in time and become a rock star, I guess. Maybe you are one. But assuming that that's not been most of our journey in life, the right answer is to do as much as you can in the time that's available to you going forward from now on. So exercise in inclusion body myositis to me is truly, in some people, miraculous. I think it gets frustrating because there are some exercises that are difficult to do. Finger flexors and finger flexor use, we don't generally isolate the finger flexors this way. Other than typing or guitar playing, maybe piano, it has us doing that. Anything we're holding, gripping, it's not just grip, it's isolation of the finger flexors, right? Where they're all moving independently. That kind of movement is really helpful if you, in my experience, if you do it every day, because it keeps your fingers from you are less likely to have the same amount of finger flexor weakness or loss of finger flexors over time. So do I think that it's going to make them stronger? Maybe not. But do I think that that trajectory of loss currently, which is sort of like this, is a less steep of a curve? Yes. So the short answer is I don't know how many hours a day he plays when he's practicing for a concert. I think it's a lot. But I think that any movement in anybody's finger flexors that you can do during the day surely will help with both not only strength, but dexterity. Okay, next, how to treat nocturnal leg cramps. This is a little beyond my expertise. Already used over-counter mineral and other treatments, thanks. So the question is, why are you getting nocturnal leg cramps? And so sometimes that question is a lot of factors. Some people get more leg cramps for whatever reason when they take certain medications. I have some patients that swear to me when they have doses of prednisone that are higher that they feel like they have more cramping. Other people say they don't notice that. It says minerals and treatment. So I think, I don't know what minerals, but some people recommend tonic water because of, I guess, quinine. I'll tell you, leg cramps are the bane of both physician and patient experience, I think. It's unclear if the leg cramps you're describing might be due to weakness. Again, I'm not knowing your personal situation, but I think that is, that's a tough question to ask. I get asked it a fair amount, and I'm not sure that I'm super helpful at giving you a great answer to treat that. I think doing what you have done is good. Getting adequate rest. The only other thing I will say is if they're really like Charlie horse-like cramps, which sounds kind of absurd, but if you're sleeping with a fitted sheet where your foot is hitting the fitted sheet, believe it or not, if these are leg cramps in the evening or overnight, some people are flexing their foot against the sheet that can cause leg cramps that actually wake you up from sleep. Short of that, I wish I had a better answer, but that's a commonly asked question that I'm not sure I have a great answer to. Do immunosuppressants help to stop the progression of the disease? Well, ideally, that's exactly why you take them. So your immune system, with all of them, which disease we're talking about? So immune suppression, so far to date, the immune suppressants that we have, we're not certain that any of them help IBM. I don't know why, because it is an inflammatory disease in itself. Excuse me, I think that's neat. Nope. So it's an inflammatory disease under the microscope. Looks like there's a lot of inflammation in many patients, or at least some, yet we don't really see any benefit from either steroids or immune suppressants with garden variety IBM. I think there are some people that have overlapping features and may benefit. So the short answer to IBM and immune suppressants is maybe. That's a little bit of a nuanced discussion with your doctor. But garden variety inclusion body myositis that never seem to respond to anything, we really don't prescribe them. Immune suppressants for the other types of myopathies, which would include quote unquote polymyositis, which I think is better probably termed under other names like the antisynthetase syndrome, dermatomyositis, necrotizing myopathy. Immune suppressants are the mainstay of how we treat those diseases because your immune system is overactive. Maybe the antibodies, those abnormal proteins you make, cause the disease, or maybe they're just a flag or a measure of disease, which an innocent bystander, but a marker, if you will. That's debatable, but it looks like in many instances the antibodies themselves might be responsible. So your immune system has a hyper-vigilant response. There's a tag of some sort that is tagged to either the muscle, sometimes people's lungs, skin, in rare instances heart, sometimes joint. And that marker says, these are foreign, please get rid of these, they are not serving you. And in fact, they're not foreign. We have no idea why a normal tissue suddenly looks abnormal to the immune system. But I've described immune suppression like a radio, and I feel like I know I'm old enough that radios used to have dials. I know they kind of don't now, but right. So this idea of turning the dial of the radio station that's playing all the way down. I want to make sure that I don't hear the music, but I know it's sort of always on. So immune suppressants don't cure the disease. You're treating the symptoms of the disease. These diseases generally are not quote unquote curable. Some patients do have long-term remission and indefinite remission, so maybe we'll call that a cure. But most autoimmune diseases start and they can shut down the music or turn down that volume, but they don't ever click the dial where you hear that click off. So immune suppressants help to turn down the volume. Now, in some instances, immune suppressants can be removed once the dial's down long enough and it remains down so far that you haven't heard the music in a long time, then we start withdrawing them. I saw something about tetanus shot, but I guess I think the short answer is you're on immune system, should you not get a tetanus shot, tetanus shots are fine. I think it sort of went away. Does anyone with myositis get to lower mycophenolate? Yes. How do you know if your dose is too high? Again, that's a conversation with your doctor. The highest dose of mycophenolate we generally use for myositis is 3 grams or 3,000 milligrams, 1,500 milligrams in the morning, 1,500 milligrams in the evening. It's a twice-day dosing regimen for most people. It's too high, I guess, if it's more than 3,000 milligrams. We generally don't prescribe more than that. And sometimes the dose can be associated with some stomach-related issues. Mycophenolate, the most common problem we have is diarrhea or other stomach-related cramping or problems there. So I don't know exactly if you know what you mean by your dose is too high, but it can, if it's causing you symptoms, it doesn't mean it's too high, but it may be not tolerated at that dose. So I hope that helps answer your question. Common for MDA5 with ILD, interstitial. So MDA5, for those of you who might be new or have no idea what that means, that is one of those antibodies, one of those self-proteins that starts to become foreign to you. It stands for melanoma differentiated antigen, and it has nothing to do with melanoma, but well, for you all. But for whatever reason, it's a targeted protein in the immune system that then tends to be associated with tough skin and lung disease in some people. So is it common, it looks like, for an MDA5 positive patient with interstitial lung disease to have inflamed non-cancerous mandibular glands, which cause numbness and facial swelling? That's a first. I have not seen that. I will say that my colleagues and I have described, one of my colleagues had a case of swollen alae, which are the little sides of the nose. So things do happen in MDA5 that are unclear. I must say I have never seen numbness and facial swelling like that, but we have seen swelling of the sides of the nose. So not common by any means, actually case reportable probably in your case. I would definitely make sure, it looks like you said non-cancerous, so I'm assuming that somebody at this point biopsied that. I have not seen that, and I think that because the disease is so rare in itself, right? These are rare diseases. So that's like a potential rare complication of a very, very rare disease. It doesn't mean it's not associated, but I myself haven't heard of that in my colleagues' cases. And like I said, we share hard cases. I think that would have come up because we would have discussed something like that. And I haven't seen that myself. Sounds terrible. I'm sorry you're dealing with that. Is dysuria or problems with urination? I guess it's probably pain. I'm assuming pain or discomfort with urination is what you mean by dysuria. Is a common symptom of myositis? No. So if you're having recurrent painful urination, I think that you want to make, I'm sure that this has been looked at by your doctor, but you want to make sure that you don't have recurrent urinary tract infections, which are more common because your immune system is suppressed. So I do see this more common in women than men, just by the way that our urogenital system is formed. So women are much more likely to get urinary tract infections than men. So male urinary tract infections are more worrisome. Female urinary tract infections, if you're prone to them before you go on immunosuppressants, you almost certainly will get them at least as often, if not more, on them. If it's not a urinary tract infection and you're having pain with urination, I think that's something that should be seen by either a gynecologist or a urogynecologist, so somebody that specializes in urology and gynecology. What we have seen, and I actually believe this is going to be published or is being published or has been published already, coming out of Australia, but we certainly have experienced pelvic floor related issues. So many women and occasional men, but more women, will describe problems with being unable to fully retain urine or having urine leaks, these kind of things, seeming unrelated to prior childbirth and other things that cause, for sure, middle-aged women and older women to have more bladder related issues. So there may be some pelvic floor related issues in myositis that I think are probably underappreciated, but painful urination or burning, that's something else that requires investigation. Oh, sorry, I think just says or can be lowered, but I don't know what that means. I'm sorry. I'm going to go on to the next one. How to reverse extreme muscle atrophy with DM. Lifelong exerciser, have home gym, any pharmacologic answers? Again, it's tough to say that without actually being personally evaluated. It's tough. If you actually have atrophy versus fatty infiltration. So again, this is a tough question to answer without knowing the individual case. There are three things that happen to damaged muscles. The first thing is inflammation. And the way we see that is using an MRI with very specific sequencing, where we're asking our radiology colleagues to assess for edema or water in the muscles. A damaged muscle can have water in it for a number of reasons, or fluid. One of those is inflammation. The second thing that happens is the muscle gets smaller. So if you're describing atrophy with your eyes, you're seeing that your muscle is smaller. The answer with that really is exactly what you're saying, is exercise, but make sure you're doing the right exercise. So getting an opinion from a physical therapist that has experience with myositis, I think, is actually very helpful. I've had some people come to visit us and then say, well, gee, I never did those exercises before. They seem to be more helpful. So making sure you're actually targeting the muscle in the way that it needs to be targeted. And it sounds like you're somebody who is very physically fit and knows exercise well, but very specific exercises are sometimes needed to bring back those particular muscles. The other thing that can happen is that they're not just atrophied, but they're filled with fat, which is called fatty infiltration. That means that a damaged muscle can not only get smaller, sometimes it actually doesn't shrink, sometimes it does, but when the myocytes or the muscle cells themselves go away and are permanently damaged, the muscle fills with fatty tissue. That has nothing to do with your body habitus, body weight. That happens to anybody thin or heavier. It's just a way, I guess, in some ways, that the muscles maintain its shape or integrity, but then it is not useful because it doesn't have contractile units. You can't contract the muscle or use it in the way that it was meant to be used. If you have full fatty infiltration, these are all seen by MRI. If there's fat in that muscle in current day, we don't know how to get that back. What happens is that if you have enough muscles around it to recruit or compensate, people use compensatory muscles to be able to compensate for those muscles that have been infiltrated by fat. If they, and I will say that I don't see a ton of atrophy in dermatomyositis that doesn't come back. In inclusion body myositis, it's a little different, that they tend to atrophy and they're very difficult to return. Again, individual case, hard to know, but I would say make sure you're doing the right exercise and make sure that if that muscle is not just smaller, but fatty filled, that we could see on an MRI, that you're using compensatory muscles and having your physical therapist work with having you be able to do that. What lab tests to initially diagnose and then follow up? Are there certain labs that are best to use for these tests? Couple things. So the lab tests that help but not are perfect to diagnose, something we use is muscle enzymes. So that's called a CK or creatine kinase. And some people use an aldolase, ALDOLASE, aldolase and CK. The caveat is that those alone, those muscle enzymes alone, particularly in dermatomyositis, the CK is not always elevated. We can't 100% figure out why that may be. It may be the way that the muscle is injured and it needs to be able to leak those enzymes into the bloodstream in specific ways. But I will say that, so it's diagnosed by a combination of many things. A physical exam that shows proximal muscle weakness. Myositis usually affects really most often outside of IBM or inclusion body myositis, the shoulder girdles and the hip girdles, right? So it's going to be your hip flexors more than anything, and deltoid muscles, biceps, triceps. Those are the way you abduct or pull your arms away from your body, the way you would do a curl or lift, or the way you'd push your arm forward. So those three muscles, and then the hip flexors, the most of any. Some people also have quadricep weakness, and so their knee extension is also affected. In inclusion body myositis, it's a bit of a different pattern where the more distal muscles, the ones further from the trunk, are also affected, like your finger flexors or your ankles. What was the other question I lost my train of thought. Diagnosis, EMG. So electromyogram, which is the needle test that a neurologist will do to take a look at the muscle, the nerve, and the junction between them, making sure that it's actually your muscle and not a nerve problem. So that's another way to diagnose it. Sometimes muscle biopsy, that's falling out of favor in some instances because we can have good antibody testing. The best antibody testing are from a few labs, which includes one from Oklahoma. It's harder to get, but for specialized testing. Quest and LabCorp, normal labs that you can utilize almost anywhere in the United States, do have a myositis panel looking for those antibodies, and those antibody panels are generally okay. There's a lot of heterogeneity, meaning that not all antibody panels really return the right answers. So it's a combination of knowing to see a specialist that can put together what you learn from the antibody panel and what you see in your clinical exam. So it's a clinical exam, it's an EMG test, MRI that I mentioned, where we take a look specially at muscles and take a look to see if the muscles are affected in ways that look consistent with myositis, which would be that signal that looks like there's fluid in the muscle. Those are really the ways to do that. Recommend a myositis specialty clinic or doctor near Louisville. Oh, goodness gracious. Off the top of my head, I don't have anybody in Kentucky that I'm currently thinking of. I would say for that, that's where Rachel and those at the Myositis Association can assist you. There's, I believe that's still true, that there are a list of experts or people who have clinical interest and expertise in myositis that's on the myositis website. I have to take a look at that. Does IVIG help with improving swallowing? Often, yes. And polymyositis, is there one drug recommended over another? Again, this is very hard to answer in the context of a question on a webinar. That requires a very close look at you physically to be able to give you an answer for that. So certain drugs do work better for certain patients, but it may be that there are certain features of the disease, a certain antibody overlapping with another disease, et cetera. So I would hate to answer that broadly, except to say that it needs a very comprehensive review by somebody who has expertise and understanding in myositis, either a neurologist or a rheumatologist. Cellcept versus methotrexate, again, those are both used often interchangeably. Sometimes we use one or the other, depending if there's more skin involved versus more lung. Methotrexate is more avoided in patients who have a risk for or underlying lung disease. Having said that, we've done some work to show that it probably doesn't matter. It's an old finding related to methotrexate that had some toxicity in the lung. At times, that's our drug of choice. It's 100% really tailored to your own story physically. So I would say that it's hard to answer that. In this context, both of those medications are used. Is it recommended to start methotrexate at the same time as IVIG? Depends on your current situation. In general, I do not start two medicines at the same time if I can avoid it, because I don't know which works. So I generally do personally a stepwise therapy where I add one, wait a little while. I've gotten some questions, I think even prior to this webinar, that said, how long do I wait to see if something works? Do I switch? In general, 3 months. Like on average, 12 weeks is what most drugs, most of the medications we use take to work. Tofacitinib and Xeljanz, which again, these are all off-label drugs. If we are able to get that approved and we start you on that, that works the fastest of all drugs we use. Short of IVIG, which can work in about a month or a few weeks in some people, mostly 1 to 2 months. IVIG works generally for, in my experience, by the second month you're using it. If by month 3 you're not responding to it, I withdraw it. I often add on if I don't get the entire response that I want to see for you and I feel like you're moving too slowly or not at all, I'll either withdraw that drug or add on another one, but starting them at the same time doesn't tell me which worked for you. So I generally don't recommend that approach. Different doctors may think about it differently. And if somebody's very, very ill, sometimes we stack things on very quickly because desperate times call for desperate measures. Can I recommend some good sunscreens? Yes. So for DM, for dermatomyositis patients, good sunscreen, by the way, I always used to think that really, isn't it a marketing gimmick? Like, is 100 SPF really any better than 30 or 40 SPF? According to my dermatology colleagues, yes. So in general, I do not work for Neutrogena. I know they've had some issues with sunscreen problems in the past, but in general, what most dermatologists tell me, and I'm only telling you with my own dermatology friends that recommend sunscreens, and they are dermatology immunologists, Neutrogena Helioplex line, any of the Helioplex lines are good, 75 or higher. So it turns out that it does matter what your sunscreen, what the SPF is. Again, I'm not a dermatologist, but that's generally what I've learned over the years. Also, wide brim, get used to like a wide brim hat. Be very careful, even 15 minutes in the sun, certainly more in the summer than the winter time, but even a few minutes exposure in some people can really spur on the rash. It doesn't only spur on the rash, sometimes it spurs on the whole disease. Ultraviolet light can really be dermatomyositis' worst enemy. I've seen it make people completely ill from skin to muscle. So be super careful. Remember also that there are, and I again thought these were a gimmick. I must say that I don't think they are. There are agents that allow your regular clothing to be washed with an SPF agent to keep your clothing also SPF, an SPF factor on your clothing. So those are the kind of things I'd recommend. But as far as the sunscreen, the Helioplex line is generally recommended by most dermatologists, at least 50, generally 75 and higher for SPF. Do I believe low-dose naltrexone can be beneficial for inflammation and dermatomyositis? So the short answer is I don't know. There's not enough scientific information in the way that I like to digest scientific information to recommend it. Having said that, I've had patients say, well, if you won't give it to me, I'm going to find it somewhere else, and I have. And some patients say, I think it works for me. I won't generally recommend it because I try to follow within reason the scientific literature, and there just hasn't been enough study. I think it's intriguing, and I think a lot of patients have sought alternative ways to treat their disease when we fail them with traditional agents. So again, I think there's a little bit of an asterisk on low-dose naltrexone. A lot of people think it's bunk and it's kind of like voodoo science. I would say I don't know, but some patients to me have reported that it helps them. I haven't evaluated that in any rigorous fashion enough to really know. So I would say I don't prescribe it, but I haven't dissuaded it if someone gets it elsewhere. Any immune boosting herbs, I really stay away from herbs like elderberry. You really don't want to boost the immune system. You want to keep it at bay. So all these things like echinacea, elderberry, no. We don't want you to boost your immune system. We want you to keep it where it is. I recognize that we are suppressing it. So you say, well, you're saying we're getting infections or we're at risk. Don't you want to pull that back up? No, because you're fighting me. If you're boosting at the same time I'm trying to reduce it, we're fighting in two directions. So I'd recommend no herbs. Herbs in general, tough. Patients of mine have tried herbal supplements. The problem is there are interactions with other agents. I was very scarred as a young doctor, as a resident, where I saw a woman come in taking ginkgo biloba, which is actually for her memory, but it caused an intracranial hemorrhage. So if you combine that with blood thinners, you can bleed. So not knowing, and I'm not trained in naturopathic medicine, for me to be recommending any herbal supplements, I don't feel comfortable doing that. Aside from curcumin or coming to me in a second, that there, I think maybe. So some people feel like that may be helpful. So curcumin, I think I'm saying it properly, but it's medical name. And that, in general, we stop maybe before surgery. It might have some potential bleeding potential, but in general, that looks relatively safe. Trying to think of other herbal supplements. Glucosamine, fine for knee osteoarthritis, for example. Chondroitin and glucosamine are fine. Other than those, I don't really like to talk about herbal supplements because I don't think I'm trained in them, and there could be interactions that I'm unaware of. So I always tell patients that I'm less comfortable. Melatonin is debated for sleep because it also has maybe some immune stimulant properties. Some of our colleagues in lupus don't recommend melatonin, so I've borrowed that information, but I don't really have any reason that I've seen a particular reaction to it, but I generally do stay away from it unless really I feel like your sleep is hurting your muscles more than melatonin might, lack of sleep. I have dermatomyositis for about 12 years. I've also had some symptoms of interstitial lung disease. What treatments do you recommend for that? I've thought that there isn't a lot that can be done. That's actually not true at all. So interstitial lung disease, depending on what kind you have, so is it the scarring kind or is it the more inflammatory kind, I recommend that you be evaluated by a pulmonologist. So a lung specialist can help you much more. And in fact, sometimes we can completely treat those symptoms. The scarring that you have from ILD, especially after 12 years, could be permanent, and we don't necessarily equate scar with disease. We measure our interstitial lung disease patients in help with our own pulmonology team by pulmonary function testing. So a specialized test to look to see how does oxygen transfer itself across the membrane between the blood barrier and your lung cells, or how much breath can you take in and hold? What is your total lung capacity? How much residual volume do you have in your lung when you inspire and then blow out all of the air in your lung? These kind of measures help us to determine what your lung looks like in a physiologic sense. And then that can tell us whether or not we think that suppressing your immune system further will help you versus whether we think you're at your peak and you're scarred at this point, we wouldn't do more. So it's not true at all that interstitial lung disease can't be treated. We treat it the same as we treat any other manifestation of the disease, but sometimes the disease is then quiet, where you've had only scar and it's not impacting your lung function, then we would not add any more treatment. Okay. What are my thoughts about efficacy of, oh, that's low dose naltrexone. Oh, particularly IBM. Again, the one patient I can tell you that has tried this for IBM seems to think it might help, not a cure, but might slow the disease progression. You know, like I said before, I just don't know. I will say that I've had a patient try low dose naltrexone for a long time with IBM. Her particular thought is it may be helping, and I don't know that it's necessarily harming. I just didn't feel comfortable without enough scientific rigor to recommend it myself. Do I know of any significant side effects of Plaquenil, for example, eye issues? Yes. So Plaquenil is required. We generally ask for yearly eye exams. In very rare instances, it can affect the eye in ways that affect your peripheral vision, for example. In general, that's been reversible for any patient I've ever seen have that. I have to tell you my own personal experience. I've used a lot of hydroxychloroquine or Plaquenil in my lifetime. I've only had 2 patients have significant eye-related disease or problems on Plaquenil. Both of those were stopped and their disease was recovered. Their eye disease was okay. As long as you have routine monitoring, you need something called OCT testing, or looking for your peripheral vision. You want an ophthalmologist, not an optometrist for this, an ophthalmologist, a medical doctor for eyes, not just optometry. Optometry is fine for your vision glasses, but if you're on Plaquenil, you want to see an ophthalmologist once a year and have them do testing. You say, I'm on this drug and I was told that I need specific visuals field testing. They will know and they should test you properly. The other issue for Plaquenil, very, 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 very rare. It can actually cause muscle disease, but again, it's so rare that I mean, I've seen it almost as a case report, exceedingly rare. Plaquenil is generally very, very safe, except for the things I spoke about earlier in some dermatomyositis disease subsets where it can cause more of a rash. Okay, I'm trying my best to get through. There's a ton of questions, and I know I have like 10 minutes. I have dermatomyositis. I was diagnosed with exocrine pancreatic insufficiency and am now on enzyme replacement. Have I seen any patients who have this diagnosis as well? I don't know that they're necessarily related to each other. I have none of the predisposing conditions for this. I've read it could be associated with autoimmune diseases. No, yet. Your rheumatologist hasn't seen it. I haven't either. I've seen it, but I don't know that I've seen it that I can recall in history of any of my patients with myositis and pancreatic insufficiency. Again, possible, but not something, and I have a lot of extensive experience, and I just don't think I can think of any patients off the top of my head that I see that combination together. I'm sorry, that's a tough thing to deal with. I wish you well, but the good news is there is replacement. Is IBM, or more specifically the antibodies, which is called, I'm telling you, see how you all are, you are honorary professors. I'm so amazed at how all of you know these things. Anti-CN1A antibodies associated with a neuropathy, or specifically the neuropathy associated with IgG versus FR3. Well, this is beyond me. Or with wild type amyloidosis. This is well beyond the scope, I think, of here. So I would say the short answer is we see both mixed myopathic and neuropathic features. So on that electrical testing on your EMG, you can see features of neuropathy or nerve involvement and myopathy. What you're asking is beyond the scope of my knowledge or anything that I know in the medical literature. I have not seen wild type amyloidosis associated with that antibody at all. We're not even sure because, as you may be aware, I'm sure you do, if you have this amount of sophistication, I assume maybe you're in healthcare or just a really good steward of medicine to ask a question of this depth. I would say that we don't even know the significance of that antibody. We do see it. We think it may portend worse disease, but again, some studies show that, some don't. We know that other people that don't have myositis have that. We saw it in our dermatomyositis and Sjogren's patients. So it's not one-to-one. So some people with IBM don't have it. Some people with other diseases do. So I don't know what the CN1, the NT5C1A or CN1A really have in store for IBM. I think we're all still trying to figure that out. But amyloidosis, no. Specific neuropathies like the one you're asking for, not personally. I have not seen that. Any nutrition recommendations for DM? Again, so this is a lot of questions outside of sort of, medicine, looking at complementary medicine. The best nutrition recommendations I can give you, or ones I would give probably to any person to stay healthy, is that sugar is almost certainly a pretty inflammatory substance. I'd stay away from processed foods and high sugar foods. I think that's true for any human being. It's also the hardest thing to do. So I know that's a big charge and a big request, but that's definitely true. So decrease processed foods, whole foods the way they come to the planet, and probably a little bit more protein versus simple carbs. So complex carbohydrates, protein, and staying away from sugary substances and processed foods. No direct literature on that, no data that I'm aware of. That's really just common sense nutrition. And I think it probably helps with any disease, certainly muscle disease. Is it possible?
Dr. Christopher Stine, can you, since we only have a few minutes, I'm going to pull a Q&A report. So I have all the questions that we did not get answered. And I may work with you to do like an episode 2, maybe sometime when you're free, because every time I look at the number of questions, it's the same number because somebody keeps adding. But can you jump to the Plaquenil question that she feels like she should stop it based on what you talked about?
Okay.
Do you see that one? On Plaquenil, about 15 years and DM stable with IVIG. Your comments make me feel like I should try to stop.
So I think you should always discuss that with your physician because you may have unique circumstances. I would never stop something that you heard on a webinar because, again, I can't impress enough where it might seem like in the general masses that's a good idea, but for your particular case, it is not. So I recommend that you speak and you say, listen, I heard this webinar. One of the things the speaker had said is that with stable disease, perhaps you could stop Plaquenil. It may be there to maintain your disease for a different reason. I can't say, and I would be very remiss to ever offer medical advice for someone who I haven't evaluated clinically. But I think that's a conversation to have with your doctor for sure. I think you should always have the conversation with your physician, like, are you sure? Within reason. I don't mean you should question your doctor. I think you should ask the question of, always be asking the question in your mind, am I on the minimally effective dose of therapy? Both doctors and patients, I think, get scared to withdraw therapy, and sometimes it's not the right thing to do. There are no good guidance. There's really not a lot of guidance. It's something we really should look into of how many patients can withdraw that therapy and how long. I generally tell patients, I'm really concerned not to treat you for at least 1 to 2 full years, even when you're in remission. And to the 2-year mark, then I'll get brave and start taking things away. There may be a very good reason why that Plaquenil is still there. So I'd be remiss to tell you to take it away, but it's very possible you might be able to remove it. It may be doing nothing for you, but that's a conversation that you have with your doctor and try to decide that. Rachel, is there anything else that you feel like there are 1,000 questions here? I am talking, and I talk at the speed of light. I'm only talking fast because there's like 50 more questions. I'm not sure I can get them all.
Yeah, that's okay. Let me see. Some people got more than one question answered, so I'm going to jump over those.
Yeah, I had a hard time looking at names. I was just looking at questions, but I do see lots from one
Yeah.
person or two.
Well, what about does myositis diseases attack gastrointestinal tissues, causing issues with types of food eaten?
So dermatomyositis definitely in some people have a very serious type of intestinal problem that is rarely described in kids. I see it a little bit more often in adults now. So I think the short answer is maybe, for sure, yes, in some people. A lot of people follow the FODMAP, FODMAP. It's a specific diet for a short while to see if that helps them, for people that have a lot of irritability in the bowel associated with it. So I think there probably are more intestinal issues than we probably realize. There's a second type of thing that happens. I've seen a fair amount and is published called lymphocytic or collagenous colitis. Lymphocytic colitis. Colitis just means inflammation of the colon. It's an itis of the large, inflammation of the large intestine. Lymphocytic is a type of white blood cell. So there's an infiltration of lymphocytes or this type of white blood cell in the colon. That requires your doctor to do a colonoscopy and then what we call blind biopsies, which always sounds terrifying. It's not like the person's blind. It means that the biopsy is done in areas of the colon that look normal, but under the microscope, it's microscopic colitis is the other name for that. So the reason it's called microscopic colitis is that they don't see any inflammation areas with the, to the naked eye, but under the microscope, we see it. So in those instances, talking to your doctor and maybe getting further testing if you're having repeated problems with diarrhea. The medications themselves can be also associated, as I mentioned earlier. Cellcept can, in some people, really be hard on the stomach, other times not at all. So medication, a microscopic inflammation of the bowel, and the disease itself are three things that we do look at. Yeah.
Okay, we have time for one more question. I was thinking, someone was wanting to know the results of and it's going to be hard for me to say it, arimoclomol.
Arimoclomol. Yeah.
I'm so embarrassed.
No, it's okay. I think the short answer.
Today's my 2-year anniversary working at TMA, and I cannot pronounce this word. So go ahead and say it. They say they know the trial failed, but were there any good information learned as a result? And what are the thoughts on current drug trials for IBM?
So real quick, the word is arimoclomol. It took me like 1.5 years to pronounce it, Rachel. You're not alone. Bimagrumab was worse. I'm getting very good at all these terms. We, as doctors in rheumatology, we have everything that is 45 letters long. It's horrible. So actually, the short answer is for that I'm not as well versed in the granular data of that trial. I don't know. I think the short answer is we learned that probably some of the outcome measures and the way we're looking at the disease, we're trying to be better about it. So you can only know if something is actually working if you have the right measure to measure it. So I think there's a lot of discussion in the inclusion body myositis world to make sure that, for example, a 6-minute walk test is something that we use a lot, but now there's a lot of debate among IBM specialists and experts that say, maybe that's not the right test. So I think one of the conversations to come out, just on a global level is I think that drug failed for many reasons, but one of them may be, at least in part, making sure you're measuring what you think you're measuring. As far as the clinical trial landscape, there are 2 drugs I'm aware of that are either being trialed now or coming out. It's sirolimus, that's an immune suppressant, sirolimus, which is also known as Rapamune, and it's ABC008, which is something called a KLRG1 a KLRG1 inhibitor. It is looking specifically at the type of white blood cell called the T cell, these kind of killer T cells that we believe may be perpetuating the disease. So that's also immune suppressant, but a very specific part of the immune system. I think we're getting into, I always am hopeful that we're understanding IBM in different ways. I think there are a lot of really good thinkers in this space where we're trying to think outside the box and trying to make sure that we have rethought whether this is truly an autoimmune disease, whether it is a neurodegenerative disease, or whether it's a little of both. So yeah.
All right. Well, thank you so much. We are out of time. We really appreciate all the work you do. She has been going since 6:30 this morning and unfortunately has to keep going until 10:30, but yet you came on and you did like a marathon speed speaking engagement. You got a lot of a high percentage of the questions answered. It's almost like a game show, but I don't have a prize for you. But we
I hope
really
you can
appreciate
listen to it on half speed. I'm so sorry I spoke so quickly, but I was just very concerned with all these questions. Yeah, sorry to, maybe we should do it twice and not half the time, but thank you.
Yeah, because there's 25 questions left and
Oh
they're
my
still coming in.
God.
So, we'll figure it out because that is a large amount of questions to go unanswered. So anyway, I wanted to thank you again, and we look forward to seeing you at our conference. And thank you to the audience for joining us for TMA's Ask the Doc this Thursday evening. Check our calendar for our next event. I believe we have an empowerment clinic on the 28th of this month. It's going to be at noon, and it's talking about managing myositis through psychosocial health. There's 4 elements that you can use to empower your journey. So we are excited to share that. So thank you. And for TMA, I'm Rachel Bromley. Good night.
Good night, everyone.